Yep.
So good morning, everyone. It's my pleasure to introduce Professor Yannick Allanore in this CAML Rheumatology series. Professor Yannick Allanore is the head of the rheumatology department at Hôpital Cochin in Paris. He also leads a laboratory in the Institute Cochin focusing on the pathogenesis and developing innovative therapies in systemic sclerosis, but also the other fibro-inflammatory conditions. And he is a former president of the group. I met Professor Yannick Allanore in 2016, initially as a resident. Then I did my master's degree with him on systemic sclerosis models. And later, I was an assistant in his rheumatology department. So today, he will be giving us an update on the pathogenesis and on the latest EULAR recommendation of systemic sclerosis, which have been recently published. So, Professor Yannick Allanore, welcome. It's a pleasure to have you here in a different city now, in Lisbon, you're not in Paris. So, the stage is yours.
Gonzalo, thank you. So I thank very much to the team, Professor Fonseca and Gonzalo, for the kind invitation. And I hope we will continue our interactions and joint projects. So you did not give me any guidance regarding what I should present today, so it's easy for me. So I decided to show and share with you some studies that to me have been important regarding new ideas or new targets or new strategies for the future of the management of the patient with systemic sclerosis. And the second part will be about the treatment recommendation, because I was the PI of this project together with Francesco Delgado, and maybe you know it was just published last Friday in Annals of the Rheumatic Disease. So I will show you the process, the methodology, and mostly the outcomes regarding what we may recommend today for the management of this patient. So as a brief introduction, and I don't know how much you are aware of this disease, but systemic sclerosis is severe condition. It is thought to be the disease with the shortest life expectancy within connective tissue disorders. And it is also characterized by a huge heterogeneity. And the most important complications or damages relate to what could be called tissue fibrosis, which is the end stage of a long journey leading to the accumulation of collagen in the skin or in the lung, therefore impairing the tissue function. In parallel, there is another component of the disease which is absolutely striking, and if you see patients with systemic sclerosis, you cannot miss that. It's the vascular component, and we usually say that the disease is starting by the Reynolds phenomenon, and then it's the beginning of a long cascade, and the vascular manifestation have a heavy burden in this disease with Reynolds, ulcers, but if we go into the organs, also renal crisis, pulmonary arterial hypertension, or heart failure. So we have a very heterogeneous disease, and the challenge is to be able to predict what may happen in a patient in the future. We have some concern regarding the vascular components, the tissue fibrosis, the both, or none of this. So this is clearly a big challenge for understanding the pathogenesis, what may happen at which time in this disease, what might be the next step. So for the understanding of the disease and the pathogenesis, the challenge, but also, of course, for the management. So very briefly, if I had to summarize the pathogenesis, and maybe you know that we have just updated the reference book, which is called Scleroderma with Springer as the editor. The new version has just been published a few years ago. And we have many review papers, and I've taken this picture from this paper done by Carol Begali-Bortwick. We think that the disease relates to some initial events that may be genetic, epigenetic, or related to the protein biology, influenced by some external factors. And it's interesting that in systemic sclerosis, we have strong clues regarding some risk factors like silica, for example. And you will see many papers coming in the next month about the role of silica in that context as an inducer of the cascade. And then these interactions are leading to autoimmunity. For sure, systemic sclerosis is characterized by very specific autoantibodies. We will touch about this later on. Fibrosis is the ultimate manifestation and the vascular component. And this is leading to very different and various phenotypes. So as said, I will concentrate on few data regarding genetic bases and the role of these candidates, some single cell data, an example of what we are doing at the lab, few data about autoantibodies, and then the recommendation. So regarding the genetic basis, we published a few years ago a review paper in which we included meta-analysis, GWAS meta-analysis. There are 3 or 4 large GWAS that have been done in this disease. So you know the model is a model of a multiplex genetic disease. So it is the interaction of many variants, each of them having a low impact on the disease, but the combination of all these variants would promote the disease and would promote the heterogeneity of the disease. So if we concentrate on lung, you can see that some candidates that have been identified in the innate immune response. And I will say a few words later on about this candidate, which is TNF-AIP3 or A20, which is a negative regulator of NF-kappa B, for which we have really some insight recently. Regarding the skin, you see that the same candidates have been identified to be strongly associated with some skin phenotypes, so mostly in the diffuse cutaneous subset. So the adaptive immune response are also some candidates that were identified. If we go more into the details, it's interesting that the large majority of the gene variants that have been identified so far are usually not functional variants. So we don't know exactly what is their biological role, but most of them belong to the innate immune response. You can recognize after this sensing signal and danger signal, all in red are candidates that were robustly identified as associated with the disease. Probably the largest number of variants belong to the adaptive immune response, and almost all the T lymphocytes differentiated factors have some candidates associated with systemic sclerosis. And it's interesting to see that some of them are also known to have a role in some other autoimmune diseases, like the FLAT4, PTPN22, the B cells. All of them have also a role in some other autoimmune diseases. So it's difficult to interpret that. So it may suggest that it has no specific influence. It's just the immune background that has a role somehow. Having said that, it's also very interesting because if we are able to identify the role for this variant and to target it with a specific treatment, it would mean that this treatment could be used not only in scleroderma, but also in lupus, Sjögren, or some other diseases. So there are pros and cons regarding the role of these autoantibodies, or this genetic variant, sorry. Initially, because of the specific trait of systemic sclerosis, we were quite confident that we would find some specific genes associated with the extreme phenotype of the disease, that is fibrosis and vasculopathy. And in fact, as you can see, only few genes have been identified regarding the cell biology for the endothelial cells. Also, some few candidates regarding specifically the TGF-beta pathway and the differentiation of the fibroblast to myofibroblast, and very few regarding vasculopathy. So I don't know exactly how to interpret that, but it has been somehow unexpected because again, regarding the very specific aspect of the disease, we thought that we would identify some genes mostly associated with the disease. So it might indicate that the genetic has no influence on fibrosis or on the vasculopathy, or it may suggest that we have not been able so far to identify the key players or the key genes associated with that. And you know that now there are more and more molecular biology improvements, and maybe in the next years, we will be more able to identify some new candidates. So having said that, for the genetic basis, we are in front of a multigenic model and a combination of genes that may promote the disease. What is missing is also the post-genomic data, because there are very few data supporting a very specific biological effect of this virus. And I would like to highlight one of them. The one I would like to highlight is TNF-AIP3. So it's easier to say A20, it's the name of the protein. So it has a key role in NF-kappa B biology. It's an antagonist of NF-kappa B. So when A20 is expressed, it's blocking the signaling of NF-kappa B. It is known to have a role in lupus, strongly, in Sjögren also. Maybe you know that in lymphoma associated with Sjögren, some mutations have been reported. But I wanted to highlight this study because it investigated the role of this gene and this protein, not on the inflammatory pathway, but on the fibroblast biology, which is something quite interesting. And this was done by the lab of John Varga in Michigan. So first of all, you can see that staining the skin is showing a reduced expression of A20 in the skin of patients with systemic sclerosis. And in parallel, there is an increase in the collagen expression in this patient. So decreasing A20, increase in collagen. This is true for skin, and they had the opportunity also to stain some lung section, lung tissue, and they also identified a decreased expression by the fibroblast of A20. So it was something new to identify that the fibroblast could express and could be regulated by A20. And then they moved to some animal models, and they have invalidated with haploinsufficiency A20. You cannot have knockout for A20 because the animal would not survive. And they challenged the mice with a bleomycin and some other strategy, and they could show that if you invalidate specifically A20 in the fibroblast, you modify the phenotype. Here, it's the backcross of CSK mice, which are associated with a strong fibrotic signature. They have backcross with CSK mice with intuitive haploinsufficiency mice, and you can see that clearly there is a further increase in the accumulation in the matrix of the dermis. And this is true for skin. And again, they also found that when there is an ablation of IN20 also in the fibroblast, you can, after exposure to bleomycin, induce a higher fibrosis of the lung. So some additional experiments supporting a specific role of A20, which I remind you is associated with the disease through some genetic variants. And finally, they have investigated DREAM, which is a partner of N20 to modulate the biology of the cells. And they found that by blocking DREAM, they can, if we concentrate on this mice, if you generate some DREAM knockout mice, you can reduce the lung fibrosis associated and observed in these mice with clearly a significant effect. So it's interesting because we have some genetic variants of TNF-AIP3. The largest biology is known about the inflammatory response, but it has also a role in the fibroblast biology, and it can be associated with a fibrotic signature of the fibroblast. And this is one example of why genetic can be helpful, because again, we started from a GWAS, and when we moved to animal models where we identify a biological role. And today, A20 or maybe DREAM are drug candidates, for having drug to modulate this in the future. The second study I wanted to highlight is this one. It's really a very impressive project that's been published by an Israeli team. And they looked at single cell analysis from a large group of patients with systemic sclerosis, 100, which is very, very large for doing single cell analysis, and some controls. In addition, from these patients, they have taken the skin and the blood for all of them, you can see here. And then they did some single cell analysis, data integration to identify which cells were overexpressed and which genes within these cells were overexpressed. So it's really a huge project. I will show you the results from the publication. In fact, they are not so numerous, and I'm sure that in the next years we will get a lot of insight from this study. One limitation, it is that there is no description of these patients with systemic sclerosis. We know almost nothing of it. It is said that we know who is diffuse and who is limited regarding skin, but nothing else. No antibodies, extent of lung fibrosis, and some treatment also that were given to these patients. We have no information about the treatment that these patients were receiving, which is a huge limitation because, of course, when you look at single cell from PBMC, if the patient is receiving mycophenolate or cyclophosphamide, there is a huge influence. So it's a strong limitation for these results. So just some maybe the main results. So they are stratified the patients. So you have the control here. So you know this UMAP data with the different cell population. This is the limited cutaneous, the diffuse cutaneous, and the first thing is quite striking. It's not so different, which is quite unexpected. And first of all, they provide the immune cell composition. So they focused on the immune cells, looking at the various populations. And you can see that they found some differences regarding macrophage, some subset of the macrophage. Naive T cells, of course, are decreased. They unexpectedly show very high NT cells in the circulation, which is not very well known in systemic sclerosis. So dendritic cells there are of course more data to support it. But in fact, they did not provide so much data in the immune cells. They concentrated more on the stroma cells and mesenchymal cells. You can see that they have been able to differentiate different subpopulations of fibroblasts, and they have mostly identified one population, which is called LGR5 fibroblast, that they found to be decreased in the context of systemic sclerosis, and particularly in the subset of patients with the diffuse cutaneous. So this is shown here, with a decrease in this population of LGR5 fibroblasts, and it's the combination of a single cell from the skin tissue and from the immune cell. They found also some other subpopulation that were modulated, but then they concentrated on this data because this type of cells are known to influence some important candidates. Maybe here you can recognize thrombospondin or collagen, which of course are important for the context of systemic sclerosis. And then they did some beautiful bioinformatic analysis because concentrating on this population of fibroblasts that they have called SCAP, they looked at, for all of this population, the potential ligand, the potential receptors, and the interaction with the other cells. We are not going into all the details, but it's very interesting that this bioinformatic tool is giving you the interaction with the other cells through which ligands and through which receptor. And of course, you can recognize, for example, here, PDGF, SERPIN, IL-1, TGF-beta receptor 2, which are connected to this population of cells. And of course, it's providing a lot of insight regarding potential target and potential work for the future. So this is the summary of what they found. They found that in the LP population, there is quite a significant population of this specific fibroblast, which is partly decreased in the limited cutaneous subset and even more decreased in the context of the diffuse cutaneous subset. And by decreasing this population, you have some important genes that are regulated, which may be decreased or increased according to their different profile. So this study is absolutely beautiful. I have to say that you must know that these data are mostly public. It means that if you have a biostatistician, you can extract these data and work on them, looking if you are interested at another subpopulation of cells, another gene or something like that. You can use this data. This is what we are doing actually, and it's a huge amount of information that could be very helpful in the future. So the next study is something done by our group that I wanted to share with you. We are working, so we did a lot of genetic, we did different in vitro stuff, but in the last, let's say 10 years, we have invested in some animal models, and particularly in the FRA2 transgenic mice. So the FRA2 is the mice which are transgenic for FOSL2, which is activating AP1 modules, and the mice are characterized by an early vasculopathy, an early inflammatory infiltrate, then alveolitis, and also pulmonary arterial hypertension. So this is a staining of the lung, and this is a CT scan that we can do using these mice, and we see in red, these are the areas of fibrosis. So the FRA2 transgenic mice are very helpful to characterize, let's say, the extreme lung phenotype that can relate to the human disease. Vasculopathy, alveolitis leading to lung fibrosis, and then probably group 3 pulmonary hypertension. And so we use this model for doing some preclinical investigation. And for this project, we were interested in Tregs. Why we were interested in Tregs? Because we looked at the T cell infiltrate mostly in the lung. So you can see that without any doubt, there is a T cell activation. And when we try to stratify the subset of the T cells, we observe that Th1 is decreasing in these mice, Th2 is increasing these mice. And we also observed that Tregs were strongly reduced in the FRA2 transgenic mice. And this was true since the very beginning, because you can see that since the age of 6 weeks, there is already a decrease in the Tregs in the lymph nodes, in the thymus, and in the circulation. So there is a strong decrease in the Tregs in these mice. So what we did next is, because Tregs were missing, we offered the mice an adoptive transfer of the Treg cells. And what we did observe, we can see here, these are the clinical mice. These are the mice receiving Tregs. You can see that after 5-6 weeks, there is, first of all, a higher survival of the mice. There is a reduced lung infiltrate, and with some marker of fibrosis. And there is a reduced vascular remodeling with a lower pressure in the right ventricle, meaning that we were able to reduce the pulmonary hypertension in the mice. So Treg deficiency, the transfer of the Treg from the same mice can modify and alleviate these changes. But we wanted to understand more what was happening, and we investigated the biology of the Treg, and particularly the role of IL-2. Because in fact, when we isolated the Tregs, we found that their proliferation was not impaired. We observed that their sensitivity to IL-2 was not modified, so the cells were still able to react to interleukin-2. But if proliferation was efficient, sensibility to IL-2 was efficient, what we observed is a really low production by the CD4 positive cell of interleukin-2. So we thought that the impairment of the Tregs was related to a lower production of interleukin-2, and we confine that in the circulation of the mice. And you can see that if we treat the mice with interleukin-2, we can restore and re-increase the number of Tregs in the lymph nodes of the mice. And this has been the the data supporting our next challenge. Our objective was to combine the treatment by IL-2 together with the transfer of Tregs, or to give Tregs alone or IL-2 alone. And this is what you can see here. So it's recombinant IL-2 with or without Tregs. And in fact, so these are the control mice with severe alveolitis. The mice receiving interleukin-2 have clearly lower lung infiltrate and lung fibrosis, and the mice receiving Tregs plus IL-2 are not doing much better, in fact. And this is also true when we measure collagen content or the vessel remodeling with, for example, the right ventricular systolic pressure. You can see the control mice, the mice receiving here they received IL-2 plus the Tregs, or here the Tregs. And so we concluded that in fact the adaptive transfer of the Treg was not very convincing by itself, and it was less efficient than IL-2 alone to restore the phenotype of the mice. And of course, it's very interesting because, you know, actually there are many studies, and in particular in France, where Gonzalo was working before working at Cochin, where IL-2 is investigated as a potential treatment to restore the Tregs, like in vasculitis or in lupus, and all these studies are ongoing. So maybe SSC could be a candidate also to a treatment of low-dose interleukin. Few other data about the role of type 1 interferon. So together with Shervin Assassi, we published again a review paper showing that we have many evidences to support that type 1 interferon is probably significantly increased in the context of systemic sclerosis. And we wanted, and we have just published again that this last days, we wanted to measure in the last series of patients the circulating levels of interferon type 1. So it was interferon 2A concentration. You can see that it's increased in the patient with systemic sclerosis, but it's not significant. Having said that, there is clearly a subpopulation with high interferon signature. So we identified that by working on the highest 10% with the highest concentration of interferon type 1. And you can see that we were able to show here, for example, that it was higher in the patients who were put here with the reduced FVC in the patient with interferon signature. And it was also true regarding NRSS, the patient with the interferon signature had a higher NRSS. These are the baseline analysis. At baseline, we could also show that these patients with interferon signature, they have a huge inflammatory response with many chemokines that are very high and very much increased. So there is clearly a subpopulation which is very much characterized by interferon signature. But our most important objective was to look at the predictivity of having an interferon signature. And in fact, we worked on 200 patients with systemic sclerosis with a follow-up of 3 years regarding forced vital capacity, and we could not demonstrate that the interferon signature was associated with a more progressive disease. So at baseline, patients with interferon signature have more skin, more lung, and more inflammation, but this is not translated by a more progressive disease during the follow-up, which is a limitation of this data regarding type 1 interferon. Having said that, we hope to learn a lot from this clinical trial that maybe you are part of, I don't know, which is the anifrolumab study in systemic sclerosis, a large phase 3 clinical trial that started a few months ago, and it's very successful. There is already more than 100 patients recruited, and of course, this will give us the insights regarding the role of interferon type 1 in systemic sclerosis. And maybe briefly to conclude, with another key aspect of the disease, I think that maybe something looking a little bit at the past, but this is the renewal regarding the role of the autoantibodies to stratify the patient with systemic sclerosis. Because I told you previously that we have some very strong, very specific autoantibodies in the context of systemic sclerosis. And of course, it must guide us regarding some biological effects, but also for the risk stratification in the clinical practice. And there has been a nice study published by Chris Denton quite recently, where they had the opportunity to compare healthy controls, patients with RNA polymerase III at the early stages, RNA polymerase III at the late stages, anti-topoisomerase at the early stages, and anti-topoisomerase antibodies at the late stages. And they have been able to take the skin from all these patients and to look using some single-cell analysis at the various signals. So it's not so easy to interpret, but you can see that if you compare patient controls, early patients, late patients, you can see that the populations of cells are quite different. And this is true for the macrophages, it is true for the fibroblasts. I think we do not have the time to go really into the details, but to differentiate early versus late stages, it's quite intuitive, but we would find some different cells or different genes to be activated. But the next step has been to go more in depth in the stratification, because now it was not only early versus late, it was early RNA pol versus late RNA pol, early anti-topoisomerase, late topoisomerase. And again, you can see that the distribution of the cells is very different. And it is showing and it is demonstrating that by working on these autoantibodies, by using the autoantibodies, we can really stratify the patient. And it can be very important for us for the stratification regarding our treatment decision. Because in one subset, you can find that macrophages are more important. In another subset, maybe it's CD4 T cells that are more activated. And in another subset, it's a more fibrotic basis with a higher sort of the fibroblast. So I would go quickly into that, but they have been able to identify the genes that were differentiated according to the the stages. And lastly, if we concentrate on the comparison of that RNA polymerase III versus anti-topoisomerase, you can see that the populations that are activated are very different. And it's particularly true regarding the fibroblasts. They identified 7 subsets of the fibroblasts that are not similarly represented in these various populations. So this is, I think, probably some guidance for the future for the inclusion, exclusion criteria in the clinical trials and for measuring the effect of the treatments. We cannot treat systemic sclerosis as a global disease. We have really to stratify the population. And to conclude on the autoantibodies, I just want to share with you a U-STAR project that we did a few years ago. And this was exactly the idea. The idea was, are we more efficient if we try to stratify the patient based on skin extent or using the autoantibody? So we compare the outcomes regarding mortality, major organ involvement, and different aspects of the disease. If we stratify the patient based on anticentromere, antinuclear, RNA pol-3, FPL17, or versus cutaneous scleroderma, limited cutaneous disease, and diffuse cutaneous disease. And we compare the way to stratify this patient according to these two strategies. And you see here some example. If we use the cutaneous-only model versus antibody-only model versus combined model, you can see, for example, that for survival, the autoantibody is more potent. And if we concentrate also on the lung, you can see that the autoantibodies are really more potent to predict the lung progression of the patient. So it is telling us that we have to go into the subset of the patient, and the autoantibodies are helpful, and we have some biological data to support this. And I think this is something we are doing more and more in the practice. And maybe you have seen that recently in the clinical trials, anticentromere patients are more and more excluded from the trial. RNA pol-3 are capped because they have different behaviors, and the population with probably the more pure systemic sclerosis is the population of the patient with anti-phosphorylated. So this is what I wanted to share regarding the biology and the recent data, and I will move on with which treatment we may give to these patients. So it has been a long journey, to be honest with you. I think we applied in 2021 to EULAR. We get the fund in 2022, something like that. And finally, it's published in 2024. So it's 3 years of work. This is the whole team that contributed to it. So maybe you remember that we published the first guidelines in 29 with Otilia Koval-Bielewska as the first author. We updated that in 2017, still with Otilia and as the PI. And so we applied, so 3 years ago to EULAR to a new update. We had to follow the EULAR rules to recruit the task force, meaning that we have to include as much as possible colleagues from the north or eastern part of Europe. We have to include the diversity of the countries. We have to be very careful regarding the sex balance also for the recruitment. And we had one EULAR methodologist, one healthcare practitioner, with some fellows, one librarian, and 2 patient representatives. And, you know, sometimes you can feel that it's a little artificial to include the patient representative, but in fact, when they are very committed, it's very helpful. It's very helpful because they tell you, okay, we go too much into the details. This is not the problem of the patient. And sometimes it's very important to have their voice to criticize what we are doing. Is it feasible? Is it realistic? Is it pragmatical? And we are lucky to have 2 active patients. So we followed the EULAR guidelines. So we have to get the consensual approach, SLR, new consensual approach, and then recommendation. So we started with a survey, and maybe we are part of this because we asked to the USAR centers, do you want to modify the questions that were asked in the previous set of the recommendation? What would be for you the key question to ask? And you can see that we received more than 100 replies regarding some question to modify, to improve, to delete, and so on. And if they were suggested by more than 80% of the participants, the question were in. So we look at this, and you can see some examples. This question is selected. This question is not selected because it's not reaching the threshold for being selected. So then there has been a huge work done by the systematic literature review. At the end, we have 31 questions with different outcomes for each intervention. And the team was headed by Alain Lescoa, and for Portugal, Tania Santiago did participate, together with Jospa Suleiman, Jelena Polic from Serbia, and Eugenia Bertoldo from Italy. And they did a huge work, but we had to look at more than 12,000 abstracts to screen all of them to see whether it was a randomized controlled trial, yes or no, how much the outcomes were reported, the quality, and so on. And they worked regarding the stratification of the question by questions that were already asked, questions that were already present but modified regarding the outcomes, or completely new questions. And then we had an hybrid meeting. It was it was exactly 2 years ago, where the SLR team presented all the results they get. I have, let's say, 5 randomized controlled trials. The outcome of this one, the drug is showing that, and then the group has to take a decision regarding if we can recommend or not this treatment. And according to EULAR, let's say, wording, the top one is should be considered. The second is can be considered. The third is may be considered, and the level 4 is expert opinion. And we graded that also regarding the quality and the strength of the recommendation from A to D. And we split that in different segments. So we will go to the main results. So the first one, it has been a concept that we raised And I think it will be a matter of work for the future, because if you look at these three domains, Raynaud's phenomenon, digital ulceration, pulmonary arterial hypertension, you can see that the same drugs, in fact, are proposed in these different areas. Calcium channel blockers, PDE5 inhibitors, endothelin blockers of prostacyclin. And so, and together with Francesco, we worked on that. We have proposed to identify what we have called a vascular therapeutic continuum, suggesting that maybe there is a vascular phenotype with some patients being enriched for severe Raynaud's, digital ulceration, and then pulmonary hypertension or heart failure. In fact, we had some clinical evidence to support that, but we have also some therapeutic evidence to support that, because we see that the same drugs are used in these different phenotypes. So if we go into the details for Raynaud's, in fact, there is nothing really new as compared to the past. Here you have the level of evidence, the strength of evidence, and the agreement within the task force. So without any doubt, calcium channel blockers is the first line treatment. PDE5 inhibitors has also demonstrated its efficacy, and IV alloprost can be used in the severe patients who failed the two initial drugs. For digital ulceration, it's new because it was not part of the previous recommendation. PDE5 inhibitors, we considered that it has demonstrated its efficacy through a randomized controlled trials regarding the prevention of new digital ulceration, and alloprost is a treatment that can heal the ulcers. Regarding the endothelin blockers, you know that only bosentan will show its ability to reduce the number of new digital ulcers. It's not helpful to heal the ulcer, but it can prevent some subsequent digital ulceration with a high level of evidence and strength of the evidence. So the new part of the recommendation, and probably this is what has taken so much time, has been to propose some algorithm, because we have now some relevant data to show the efficacy of the treatment, of the drugs, but how to use them, which strategy we can use. The problem is that we do not have trials regarding second line and third line, but we tried, according to the data we have, to raise some potential algorithm. So in the context of Raynaud's phenomenon, the recommendation is to start for all the patient calcium channel blockers. If you reach the objective, you can continue the treatment. If you are not reaching the objective, or if you have complication, or if you have side effect, PDE5 alone or in combination should be considered. And if you move to digital ulceration, in addition to calcium channel blocker, you have to consider PDE5 and or alloprost for healing. And if you want to prevent some subsequent digital ulceration, bosentan or PDE5 are recommended in that context. So this is the first algorithm that we are proposing regarding Raynaud's and digital ulceration. For PH, there are many data coming from the idiopathic field of pulmonary hypertension, but we have some strong evidence in the context of SSC-PH. And the largest evidence is that nowadays, the first-line treatment in the context of PAH should be the combination of PDE5 inhibitors and endothelin antagonists. You can see that there is no name regarding which drug to use, but the idea is to use one drug belonging to this class of treatments, PDE5 inhibitors and endothelin receptor antagonists. It is clearly the first-line treatment that should be given to all the patients for whom to make the diagnosis of pulmonary arterial hypertension. Then there are some evidence for epoprostenol, some other prostacyclin analogs. Rossigrat has a lower level of evidence, and now we have some data to support that anticoagulants should not be used in the context of SSC and PH. You know, sometimes it's given in idiopathic PH. There are some data to support that it should not be given in the context of the SSC PH. And this is the algorithm. The challenge is that our patients who are diagnosed for SSC PH, usually they are already receiving some treatment. because they have Raynaud's phenomenon, they have digital ulceration, so they are already receiving calcium channel blockers, PDE5 inhibitors. So it has not been easy to draw this algorithm. Having said that, again, if there is no background vasodilators upfront, combination is recommended, and then a regular follow-up, and then you know the objective through the guidelines in idiopathic pulmonary hypertension. You have to improve the patient regarding the dyspnea class and some other risk factors. And if it's not improved, you have to increase the treatment and then from there. So this is nothing very specific, not very new, but we have clearly opportunities actually in this. And the last one is about skin and lung. And we have to say that as we identified the vascular therapeutic continuum, if you compare what has been done for skin and for ILD, you can see that MMF is in the two, tocilizumab is in the two, hematopoietic stem cell transplantation is in the two, and rituximab is in the two. So as we propose a vascular continuum, we are proposing an immune suppression continuum that could go across skin and lung fibrosis, because we identified that the same drugs are in development in these two conditions. So if we go to the details, for skin, there are evidences to support the use of methotrexate, mycophenolate, even if the data are not very robust, to be very honest, or rituximab can be offered for the management of severe skin condition in the scleroderma patient. And we give a recommendation of 1B for tocilizumab, because you know that the trial was negative regarding the primary objective. Nevertheless, there was a trend of improvement. And if the sample size had been larger, or if the follow-up had been longer, probably we would have obtained a positive clinical trial. So it could not be 1A, but it's 1B regarding tocilizumab for skin. And for the lung involvement, you can see what is proposed in the 1A subclassification, because for lung, we have at least one randomized controlled trial versus placebo and one randomized controlled trial versus cyclophosphamide, supported that MMF could be helpful, cyclophosphamide can be helpful, or rituximab, given the recommendation that this treatment, these three treatments should be recommended for the treatment of SSc-ILD. Then we have a single trial, but that is very large, that is the nintedanib clinical trial that demonstrated its ability to reduce the FVC decline in the patient with severe ILD. And so the recommendation is that nintedanib should be considered alone or in combination with MMF for the treatment of SSc-ILD. And regarding tocilizumab, so I previously said that it did not work regarding specific skin involvement, but you know that in this skin trial, the effect on lung has been very, very large. Nevertheless, it was a secondary objective and not a primary objective. That's the reason why the level of recommendation is 1B for tocilizumab in the management of the SSc-ILD. And we have spent a lot of time in that to, again, try to provide some guidance regarding which drug to use. Same issue, because when you treat a patient with scleroderma ILD, usually he has already systemic sclerosis and you have already offered a treatment for skin. So the question is, do you want to change the treatment on skin? Do you want to add something? It's not so easy. So we suggested that if the patient is already receiving MMF, then there is the consideration of adding nintedanib to MMF. If the patient is not receiving any immunosuppressant, the three drugs that can be discussed are MMF, rituximab, or cyclophosphamide. And we have identified a very specific subset because of the tocilizumab trial. If the patient is in the first 3 years of disease duration with high level of systemic inflammation, particularly with anti-topoisomerase, probably tocilizumab should be considered. Whatever your strategy as the first line, you always reassess the patient to know whether after 3 to 6 months is progressive or not, is FVC deteriorating, yes or no, then to take a decision. The comment we provided is that we should not be too fast in changing the treatment because SSC-ILD is usually not very fastly progressing. It's different from IPF, so take the time to analyze the symptoms, analyze the FVC, maybe redo an HRCT to be sure that the patient is moving in the right direction. Do not change all the time the treatment so that at the end you don't know what you are doing. So this is not a very rapidly progressive ILD, scleroderma, so you have the time to manage the patient. So I will go more quickly to renal crisis and GI or musculoskeletal where we have no treatment. We have also discussed about hematopoietic stem cell transplantation that we feel is very difficult to position in that context, in the context of the development of many trials. And you see the recommendation is that may be considered for the treatment of selected patients with early diffuse subset and poor prognosis in the absence of very severe cardiopulmonary involvement. So actually, there are a lot of questions regarding whether some patients may benefit from hematopoietic stem cell transplantation. So I will skip that. And so the conclusion is that for the first time, we have some evidence to support that synthetic targeted synthetic DMARDs or biological DMARDs are available in the context of systemic sclerosis. We have some guidance to be able to help the clinician for the management of these patients. We hope that in the future we may improve the biology to guide our treatment. And as you will read, the last part of the discussion is how we have to think now about combination of treatment. This disease is complex, heterogeneous. We have many drugs that are showing some evidences. Of course, we will never be able to be very strongly efficient in this patient if we do not combine the treatment. Having said that, how to combine? 3 drugs since the beginning with a step down, 1 drug and second one and the third one in the step up strategy. This has to be done in the future, but there is no doubt that we will have to combine the treatment if we want to be efficiently fighting against systemic sclerosis. In the last picture are the people in Paris working at that and the support of Zula and thank you for your attention.
Thank you very much, Professor Yannick Allanore. Do you have any questions?
Thank you very much. It was a great talk, very informative. And I would like to make a comment on IL-2 and a little bit of a surprise seeing that the animal model improves with IL-2, but then with the transfer of regulatory cells, it doesn't work. So it might be that the transfer is hard to be done and to have any effect. That's a possibility. The other one is that IL-2 is acting not only on the pushing of CD25 FOXP3 cells and is doing other things in addition. The experience of IL-2 came from graft versus host disease, and I'm not familiar with it, but the idea that I got because of the several revisions that we've made for assessing the possibility of treating patients many years ago, very severe patients. The concern is that IL-2 is also working on other cells, other T cells, B cells, etc. So in some cases, it induces severe phenotypes of inflammation also, paradoxically, because of the other sites where it is interfering. So how things are going regarding that? Safety of IL-2?
So think about the fact that our mice are transgenic, so they have an active biological condition promoting the disease. If you transfer Tregs once at the very beginning when they are newborn, then you have an initial treatment, but then there is probably the phenotype that is ongoing with recurrency of the biological signals that probably will not block the phenotype for the rest of the life of the mice. So this is different from the IL-2 because the IL-2 you can do reinduction in the mice, and this is probably why it was stronger at the term that we look at. The point is that for IL-2, the limitation is immunization against IL-2 that we did not observe in our experiment because it was only 5 to 6 weeks. But the challenge is to be able to retreat the patient with long-term treatment. But this is an option, or it can be, you know, to pass a flare of the disease. So I'm quite interested in that, and we will see the outcomes of what is done in lupus, for example. But it seems to provide some benefit. So I think maybe the story will continue.
But the other thing in the recommendations and IL-Prost,
Yeah.
because I felt that regarding pulmonary hypertension, the presence of IL-Prost and other prostacyclin antagonists have been proposed now as an alternative for pulmonary hypertension, right, in the guidance. And some of the drugs have had in the past, at least, what was described as a paradoxical hypertensive response when they were in the valley of the effect. So this has been described for inhalators and other ways of treating vasodilators. So how has this story evolved? So there's no problem regarding that one.
So, you know, epoprostenol in the context of idiopathic pulmonary hypertension is thought to be a bridge before transplantation, because you have tachyphylaxia, you have to increase the treatment, and you cannot stop the treatment. I think it's very different for us, and this is where systemic sclerosis can be an opportunity, because in idiopathic pulmonary hypertension, you have a patient referred to a center because of heart failure related to pulmonary hypertension. It's different in systemic sclerosis because you identify the patient before he has some pulmonary arterial hypertension. And if we're able to get some criteria to identify this patient very early, we will have identified them before they have heart failure, and then we will not have to use some strong multi-drugs in this patient. That's the reason why the old early combination makes sense in our patient. You know, if you have SSC patients and you see a decline of DLCO with a normal CT scan, it is telling you that there is something wrong in the lung vasculature. If you see that a slight increase in the pulmonary arterial pressure, if you do a stress challenge during catheterization, you can identify this patient early. And then we will not have to use some so strong treatment like IV epoprostenol that is offered to the patients.
I'd like to know what you think about the CAR T cells, because I don't know if you recommend in the future, but think about.
It's, of course, a really up-to-date question. So what I can say, trying to be politically correct. Remember the story about hematopoietic stem cell transplantation. It was a miracle. 1 case report, 2 case report, 3 case reports. So of course there is a huge bias in the case report that are published. But when the patient is dying after treatment, you do not publish the observation. And to me, it has been a critical pitfall of the hematopoietic stem cell transplantation because they have not worked enough to identify which criteria you can use to select your patient, to who you can take the risk to use a very aggressive treatment. And the same question will be asked to the CAR T cell, because of course I read, like you, the beautiful clinical case report that I published. It seems that in lupus, it's particularly brilliant with a long-term effect, repopulation of the cells, reset of the immune system. Have a careful look at the scleroderma cases. At the very beginning, none of them had ILD because it's more challenging to give a strong immunosuppression in the patient with lung insufficiency ILD, because if you have any first flare of inflammation, it can promote the progression of ILD, or if you have infection in patients with severe ILD, in which the patient may die because of that. It was very interesting, the last case report published in Annals of the Rheumatic Disease, a beautiful early diffuse anti-topo patient with ILD at the very beginning. They give the CAR T cells, the skin is improving, the lung is stable, but after 3 months, they have to re-give MMF. After 6 months, they have to re-give nintedanib because lung was not moving. And in fact, the patient was not doing very well regarding the lung. I'm not saying that it's not working. I'm just saying that systemic sclerosis is different from lupus, different from Sjögren, different from myositis. Systemic sclerosis has this very specific signal of fibrosis, which is very challenging to revert. So we will have to be very careful regarding the selection of the patient and who may benefit and for whom it may be harmful. So I cannot bet what will be the future. I hope that it will work, but I hope that our community will be strong enough to guide the pharmaceutical company in a very accurate selection of the patient who may benefit from it. There are 2 trials that are starting, Novartis and BMS, and we will see that. Okay.
I think I agree with you because it's very easy for us to think
Of course.
patients to begin of and the patients start to stay begin but after 5 years they will allow
And yeah, and there are some recent publications to show the outcomes of patients receiving hepatopoietic cell transplantation versus rituximab plus MMF. And if you look at the outcomes, they are almost the same. And with rituximab MMF, you know what you do. You are not engaging in the very long term with the risk of leukemia or bladder cancer or things like that. So we have some drugs available. By itself, no one is very definitive, but by a combination, maybe we can improve the patient in a quite safe way.
Thank you, Doctor, for the conference. I have 2 questions. One is, what is your opinion in the BAFF receptor blockage pathway in treating scleroderma in the BAFF receptor? Like belimumab and these other drugs that are having some studies starting to recollect patients. And the second question is related to PAH treatment. Most clinical trials were made with the old definition of hypertension. So these patients between 20 and 25, what is your recommendation?
Yeah.
Should we treat them in combination therapy or maybe monotherapy could be an option?
So regarding BAFF, I'm not much aware of very specific data in the context of systemic sclerosis. Having said that, I have to say that rituximab is the first treatment that demonstrated in the Japanese study at the same time skin and lung benefit. And if you remember what I showed you regarding the autoantibodies, the role of autoantibodies, we have now more and more evidence to support that at least the anti-topoisomers are probably pathogenetic, so they promote the perpetuation of the disease. If you have a treatment very efficient regarding the B cell activity, my bet would be that it can help. Again, not alone, not only using this strategy, but I think it's part of the management. So there is the belimumab trial that is ongoing. It's a very challenging trial because they decided, in fact, to do a lung trial, and they want the patient to have active lung and active skin at the same time, which is very challenging, and they are very disappointed because there is almost no recruitment. I think they have 3 patients recruited by now, because they have been looking at the 2 specific phenotypes. And you have to do some compromise when you look at that. You have to think about the feasibility. So my bet is that probably belimumab can be helpful. We will see if the trial is successful and if there is a more specific effect in some patients. Regarding the new definition of pH, you know that the mean pulmonary arterial pressure has been moved, but EVR has been added. And in fact, if you look at the series, the fact that you add a PVR increase in the definition of pH is in fact telling us that you are selecting the same patients. So I think that we should apply the same strategy as the one proposed by the idiopathic community with upfront combination therapy. And then we do not have so many patients between 21 and 24. But again, the PVR criteria is important because if there is really a PVR increase, these patients really have pulmonary arterial hypertension and they may benefit from the active vasodilators that are available.
Hi. I would like to know your opinion. What you consider now for as a first-line therapy for rapidly progressive severe skin involvement? Because classically, cyclophosphamide was used, but now it's not part of the guidelines. What is your opinion?
Yeah, so I agree with what you said. Previously, cyclophosphamide was offered, and we wrote together with Marco Matucci an article about why cyclophosphamide is not anymore a first-line treatment in systemic sclerosis. So if in front of the diffuse inflammatory progressing patient, I think today the treatment is either MMF tocilizumab or MMF rituximab. If you have to make a decision, to me, the first combination would be MMF tocilizumab, because if you are analyzing after 3 to 4 months that it's not working, you can switch tocilizumab to rituximab. If you start rituximab first, it's more challenging to decide when you can add another biologic. Is it after 4 months, 6 months? Because if you have still 0 CD19 circulating cells, you can be in trouble regarding the safety of the treatment. So my recommendation, and I think this is what we're doing actually in our group, is MMF toci moving to MMF rituximab if we do not have a great signal.
So the combination of the two.
Yes.
And but if the patient has a normal CRP, would you still go for tocilizumab?
That's a good question. The argument I will use is the fact that it's easier to switch from toci to Ritux rather than the opposite. If you switch from Ritux to toci, maybe you still have an effect of rituximab, and in fact you have a triple combination, which can be challenging regarding infection. But you're right. And we will show at the ACR, thanks to a beautiful Italian study, that clearly the patient who respond the most to tocilizumab, without surprise, are the patients with high CRP and also anti-topoisomerase antibody. So exactly the early inflammatory profile of the tocilizumab study.
One question also regarding tocilizumab, because it looks from the recommendation through evidence. Sometimes we have these very recent systemic sclerosis with progressive skin disease and lung disease. And we know we have to start from combination therapy, usually with MMF. And then the question we have is either we start with rituximab or tocilizumab. We have this feeling, you know, for sure, because there are no head-to-head trials compared with rituximab to tocilizumab. If we start tocilizumab, maybe the patient is a missed opportunity for the patient, because have this feeling that rituximab is maybe more efficient for progressive lung disease than tocilizumab. What are your thoughts?
No, I think we have no argument to support that. The effect size of tocilizumab is much larger than the one of rituximab. And again, the short half-life is really an added value, because same comment, it's easier to switch secondarily. Again, systemic sclerosis is not a disease that is fastly progressing. So if you have the time before taking a decision, you should not rotate too quickly the biologic. So giving 3 to 4 months of tocilizumab to see whether you are able to stabilize the FVC, looking at the changes on HRCT, and then take a decision, and then add rituximab. But I would not say today we have evidences to say that it's more efficient, because your comment regarding skin, You know, if you do a meta-analysis of the two tocilizumab studies, it's positive regarding MRSS. So we can say that we have a signal for tocilizumab and skin. What has been disappointing for tocilizumab is that, okay, today we want to improve MRSS, we want to improve FVC, but our goal is to improve the quality of life, the patient feeling, the patient perception. And what has been particularly disappointing in the tocilizumab study, in fact, there was no signal regarding pain, fatigue, energy, daily life. Nothing was moving, which is really unexpected because I'm sure you are treating rheumatoid arthritis patients. It's very striking to see that it's going back with lower inflammation and so on. So this is the disappointment with tocilizumab. The good news is the effect size regarding FVC, which really is very, very, very large.
Question. You showed a lot of targets, candidates, candidates that are identified by KOLs. In the USTAR database, we have right now 23,000 patients. How do you think artificial intelligence can make the bridge between all these clinical data, huge clinical data, and all these targets that are appearing in the literature?
It's a very good question. So we are actually, so the USTAR database, it's a longitudinal project, multi-center, 250 centers, and actually we have more than 23,000 patients recruited with a follow-up. And so we have started to work with some colleagues who have skill in artificial intelligence for doing some clustering. Are we able to identify maybe some subset that we do not feel by now because it's too rare or too specific? And I agree with you, maybe in the future we'll be able to identify more, let's say, CRPI plus this autoantibody, then you have really to take a decision in the very early years. For anticentromere, scleroderma, there is no risk regarding survival, but these are intuitive. What we expect from artificial intelligence is to identify new cluster, new subsets of the disease. But this is a work that is ongoing. We are doing actually that in mortality, but of course for any of the organ manifestation, we will do that. And we hope to get some improvement.
Questions? Thank you very much, Professor Yannick Allanore.